Where is Makrand? मैं
He
मकरंद कहाँ गया?
he will join in some time. We are going live in 3 seconds. Three,
और
2, 1. Doctor, we are live.
Good evening, everyone. I'm Dr. Rishima Ganiga, and on behalf of Zorvia Healthcare, I extend a very warm welcome to all our esteemed delegates and faculty members. Today marks a special milestone as we launch the first edition of the Zorvia Masterclass series, and we are privileged to begin this academic journey with an eminent speaker. It is my honor to introduce Dr. P.C. Mahapatra, Professor Emeritus in Obstetrics and Gynecology, former president of FOXY representative to South Asian Federation of OBGYN, and the founder of the Prachi Institute for Mother and Child Care. A visionary leader, exceptional teacher, and inspiring mentor, Dr. Mahapatra has devoted his life to advancing medical education, nurturing generations of gynecologists, and improving women's healthcare. His extraordinary contributions have been recognized with numerous prestigious honors, including the Foxy Vidya Vibhushan Award, the Foxy Lifetime Achievement Award, and several other national lifetime achievement awards, reflecting his enduring impact on the profession. Today's masterclass, Mistakes in My Life and Lessons Learned, promises to be an inspiring session where Dr. Mahapatra will share the experiences, challenges, and invaluable lessons from his remarkable professional journey. Without further ado, I request Dr. P.C. Mahapatra to take over the session. Over to you, sir. Thank you.
1 minute, sir. I invite Allah sir to speak a few words. Allah sir.
Yeah. So on behalf of Zorvia, it gives me immense pleasure to welcome the August gathering of the first episode of Masterclass in Obstetrics and Gynecology Solving Clinical Dilemmas by Dr. P.C. Mahapatra, sir. Right. Before we get into the actual session, a brief introduction about Zorvia, since this is the first episode. Zorvia has been formulated and launched in the month of January with about 1,350 Zorvians across India. 1,200 Zorvians represent Zorvia in the field through two arms, Zorvia Force 1 and Zorvia Force 2. And we have about a strength of about 150 at head office supporting the entire field activities. The formation of Zorvia and Zorvia entirely is run on three basic principles or values, which is trust, innovation, and patient accessibility. We all Zorvians believe that it is very, very essential that we are able to develop trust between the medical fraternity and the patients by providing quality medications, by providing innovative medications, and above all, patient accessibility. That means our medicines and our services are available to all. Towards this direction, it gives me immense pleasure to share with you that with good wishes of the entire team, we have been able to launch 6 products for the first time in India across the spectrum in various specialties. Gynecology is one of the most important important specialties which we focus on, and we believe that this is an area of interest, and therefore we have introduced a couple of brands to serve pregnant women as well as ailing mothers across from pregnancy, or you say from puberty to menopause, and even the young children through our products. We have to our, what you say in the product range, a wonderful product which is Zorberry, a first time in India combination of magnesium L-carnitine. We have progesterone, nanonized progesterone, and we also have an innovative iron which is named as iLip XT. This has been the focus of our endeavor to bring you quality medicines with innovation. Today we are exceptionally pleased to bring to you this initiative which has been guided by Dr. PC himself, the Masterclass in Ops and Gynae. I would request, to show a short video before we actually begin with Sir's session. A short video on Zorvia, please.
Healthcare today is evolving faster than ever before. New challenges, new expectations, and a growing need for therapies that are innovative, accessible, and focused on improving patient outcomes. It is this need that inspired the creation of Zorvia, a new age healthcare organization built on science, rooted in trust, guided by purpose, and committed to making a meaningful difference in patient care. At Zorvia, we believe that meaningful healthcare begins with understanding the needs of both patients and healthcare professionals. This belief drives our commitment to deliver trusted therapeutic solutions across diverse areas of care, supporting healthcare professionals across a broad spectrum of care, from infection management and respiratory health to diabetes, cardiovascular, and metabolic care, and across specialized areas including gastroenterology, women's health, pediatrics, and pain management. Zorvia is building a diversified portfolio designed to address evolving healthcare needs across every stage of the patient journey. At the heart of Zorvia are three defining strengths: deep therapeutic expertise, helping address evolving healthcare needs through focused scientific understanding and relevant therapeutic solutions; science-driven innovation, transforming research, insights, and clinical understanding into therapies that create meaningful impact; and a patient-centric approach, ensuring that every solution we bring to healthcare professionals ultimately serves the needs of patients. Together, these pillars shape our commitment to advancing healthcare with purpose and responsibility. Today, Zorvia's commitment towards healthcare takes an important step forward through a strategic co-marketing collaboration with Eris Life Sciences. This collaboration brings together Zorvia's deep understanding of infection management and healthcare engagement with Eris Life Sciences' trusted portfolio and commitment to quality, thereby supporting healthcare professionals across critical care and anti-infective management. As part of this collaboration, Zorvia will now promote the complete portfolio of Eris Life Sciences' critical care and gynecology portfolio alongside its existing offerings. This will expand Zorvia's therapeutic reach, enhancing our ability to engage across a wider spectrum of patient needs. At Zorvia, our journey is guided by a simple belief: healthcare should be innovative, accessible, and patient-centric. As we continue to grow and build meaningful partnerships, our purpose of shaping the future of healthcare remains unchanged. Zorvia Healthcare, where healthcare is redefined with trust, innovation, and accessibility.
Thank you so much for playing the video, and we sincerely thank the August Gathering for giving us time and watching the video. One more announcement before we just hand it over to PC sir is that today, in last 4 months, we are incredibly happy to share with you that Zorvia is into top 100 pharma companies across India in the month of June. This is dedicated to all entire medical fraternity who has shown tremendous faith in prescribing our medications, and we are sure that your patients have benefited. Thank you once again for making this a possibility in terms of making us a top 100 company. Now it's my pleasure to hand over the entire session to teacher par excellence, Dr. PC sir. So we'll look forward to your blessings, good wishes for the organization, and please take the session ahead. Thank you so much.
Thank you, Team Zorvia. and especially Mr. Alat, Sanjay, Rishima, and the whole team of marketing team of Jorvia Healthcare. And 1350 Jorvians across the country for giving me again an opportunity to have a scientific ongoing masterclass in the field of obstetrics and gynecology spread all over India. My viewers, my lovable viewers, my students, my colleagues, my seniors, and my grand students and great grand students, ladies and gentlemen. Well, Rishima, you have overestimated Dr. P.C. Mahapatra. I'm not that brilliant. I am an ordinary teacher, and teaching is my passion. And that's why I love to have teaching across the country for that. Well, this particular episode, initiation of the episode, thanks Alad and whole of the team, Jorvia, for giving me to spread the knowledge every month as we started before. And here in this particular thing, it's very, I think, pleasurable on my part to start this particularly on this auspicious day of Rath Yatra. From Puri, Lord Jagannath is traveling the journey, and this is a universal, I think, most wanted epitome of the philosophy of the Hindus to see that. And that's why I'm very fortunate to start this particularly on 16th July of this particular episode. And today, I think this is a masterclass in obstetrics and gynecology from basics to advanced. And this is the episode 1, starting from Rath Yatra, 16th July 2026. I'll focus attention on mainly the solving clinical dilemmas for that in the series to continue. And this is a Jorvian initiative, and I thank this particular pharmaceutical company who is close to my heart. And the mission is about strong path towards good health. And we have seen your corporate videos. We are convinced about how innovations in science combine together in the field of medical practice or various faculties for that. And of course, it's my derivation today. I will say a lot in this particular thing when you announced, and we all are happy to know that you are now with the 100 best companies in the world for that after 4 months. I wish that by the end of this year, you will be the one of the 10th company in country, and after a few years, you'll be the number 1 in the country for that. That's my dream today. And my derivative of the company, Jorvia, I have given this name as a jest of reproductive value, innovation, and acumen. This is befitting to the company, fulfilling our academic purpose for that. Well, why I have selected this particular topic? In many occasions also I have shared this particular few of these components of this topic in various forums for that also. Those who have listened it, they must know. But I have modified a little for that. And purposefully I have made it before initiating a particular subject for that, because this is a learning lesson for not only to me, but to everybody for that. We don't learn by our successes. We learn by our failures, and that is important in everybody's life. If there is a failure, one must learn for that if introspect properly. And I'm not here to speak about my success stories for that for the last 47 years. I will share some of my mistakes I have done in my life and what lessons I have learned for that. Time doesn't permit me to elaborate all the mistakes I have done for me during the last 4.5 decades, during the short period of about a couple of hours. And believe me, at this particular age, with 47 years of practice in obstetrics and gynecology, I believe that I have done more mistakes than anybody in the audience or anybody in the medical faculty or my viewers present over here today. And therefore, I thought I will share some of my real life situations for that, which has given me to learn not to do this mistake in future. And I will advise you also that you introspect your mistakes, and then only you can improve and I think successful in medical in your own profession for that. And that's the main purpose for which I will do that. This is again a common and favorite slide of mine. This is a story of a gynecologist. It's not a easy job to become a gynecologist. The story of a gynecologist, everybody must have known for that, how much pleasure, how much pains they have got it for that. But we gynecologists believe that the painful pleasure or pleasurable pain, whichever way you interpret for that. मैं 12th में था, वो 12th में थी. मैं MBBS में आ गया, वो BSc में थी. मैं MBBS में था, वो MSc में थी. मैं MBBS में था, वो PhD में थी. मैं MBBS में था, वो डॉक्टर बन गई. उसकी शादी हो गई, मैं PG एंट्रेंस दे रहा था. वो 2 बच्चों का मां बन गई, मैं MD गायनिक कर रहा था. बच्चे 5 साल होकर स्कूल जाने लगे, मैं सीनियर रेसिडेंट कर रहा था. बच्चे 10th पास हो गए, मैंने हॉस्पिटल शुरू किया. अफसोस है ये कि आज उसकी ट्यूबेक्टमी है और मेरी एंगेजमेंट. Story doesn't end here. Journey continues with pains and pleasure. I think this is the life of a gynecologist. In some other episode, I will again reveal the whole life of a gynecologist for that. Success or failure combined for that. As far as mistakes are concerned, I have done a number of mistakes both in my personal life as well as professional life. I don't want to convey this in this particular forum about my personal mistakes for that. And professional, I will share it for my development, for my knowledge, as well as updating all of you for that. There is a saying, anonymous doctors say, that there are 3 blunders in life. There are 3 blunders in life. First blunder, to become a doctor. Second blunder, to select doctor as a life partner. And third blunder, to create doctors as a progeny. This is by choice or by chance, I don't know. But I have done 4 blunders in my life. I have become a gynecologist. My wife is a gynecologist. My only daughter is a gynecologist. And the son-in-law is also a gynecologist. I have done 4 blunders in my life. I don't know whether by choice or by chance this has happened for that. Well, many senior people tell that I do not face complications or I have not seen surgical problems. They want to project what are the success stories for that. I think I believe that they are either not doing any surgery or they are greatest liars ever possible in the earth for that. Now let's deal with the situation analysis and of my own real life stories and introspect, scientific analysis, and then action with the confidence, so that in next series of cases or similar cases, I will not do the same mistakes or blunder for that. Situation 1. This about 1979-80s, when I was a postgraduate in gynecology, admitted in postgraduate. Mrs. X, G3, P2, third gravida, para 2, both spontaneous vaginal delivery. Last childbirth is 3 years ago. At 38 weeks of gestational age, admitted to labor room at 9 p.m. with abdominal discomfort since 4 hours. I examined. Uterus was tom size. Contraction was mild. Relaxation was good. Fit lot 140 over minute. And PV examination, at that time it was only your head and your 2 fingers. Nothing else was there for that. And your stethoscope. PV examination revealed cervix fully faced, os fully dilated, membrane absent, head at 0. But the whole night there was no progress. A multigravida admitted at 9 p.m. and even in the morning hour at about 8 a.m. I didn't find any progress for that. And the patient is not delivered yet. I gave a call to my RS. RS came, did a PV examination, found cervix long, os closed, no abnormal discharge, patient not in labor, transport to antenatal ward. This has shocked me. Believe me, I thought I will leave the gynecology and enter into some other profession for that also. I was so depressed that even I could know the PV examination cervix long os closed. I told that his cervix fully dilated, fully effaced. And that has really puzzled me. And that day, I thought how to do a PB examination. I said that next 1 month of my duty in labor room, the only agenda of mine to do a PB examination to find out the cervical effacement and dilatation, which I had forgotten for that. I asked madam how to do a PB examination, how to know the effacement and dilatation. Then she told that yes, you introduce 2 fingers, you find out what is the length of the cervix that is projecting to the vagina, and if it is gradually, it is shortening, you find that it is a partially effaced or fully effaced when the whole cervical length is obliterated to the vagina. And about the dilatation, if your 1 finger goes, it's 1.5 centimeter. If 1 finger is loose, then 2 centimeter. Then 2 fingers, 3 centimeter. Then two fingers loose, 4 centimeter. Then I asked when, then it little loose. How can you know? Up to about 4-5 centimeter we can know. But beyond that, it is just a guesswork. Madam told that yes, it's approximation and all that with a subjective finding you discuss with that. I referred all the books, the then textbook of obstetrics and gynecology, and nowhere it is mentioned how to know the degree of dilatation for that. Then I asked and wrote a letter to the editor of 3 main books for that, the Holland and Bruce, C.S. Daw, and another book, British Obstetrics and Gynecology. And I didn't get any response from them. And another book I've written, the Lange publication was their latest. I suggested them that to me, I think the procedure should be something different for that. So that then I thought from my own analysis, I thought up to 4 centimeter is accurate for that. Beyond that, it is important for that. Maximum up to 5-6 centimeter you can diagnose. Otherwise, it is just an assessment, a subjective assessment for that. Then I thought I recommended to the Lange publication that what is the ream of this cervix which is left behind, you find out. And the ream of this cervix can be measured in centimeter. If 2 centimeter of ream is there, on either side, a whole around 2 centimeter ream is there, then 10 minus 2, I think 2 centimeter either side, 4 centimeter is 6 centimeter. If 1 centimeter is there, 10 minus 2n, where n is the breadth of the cervical ream which is left behind for that. I formulated that and forwarded to the Lange Lange publication for that. And believe me, the next edition, they added my version for that. The cervical dilatation beyond 5 centimeter, you can assess 10 minus 2n, where n is the breadth of the cervical ream which is given. I was so happy by that. That is it is not a subjective, it is an objective assessment for that. So acquiring a skill is the greatest wealth of a professional, and a knowledge acquisition, a good guide is essential for that also. And along with that, you apply your brain, you apply your thinking, how to solve unsolved situations for that. And that has been a great learning for me by my mistake, which I had cried and trying to leave the profession of the department after finding my fault and blunder. I've done it in that particular night. Situation 2. Mrs. Y, 46 years, para 3, all previous cesarean section. Came with a heavy menstrual bleeding for 1 year, obese, hypertensive, diabetes. And on weight is 110 kg, pallor was mild. So obese parietes, per abdomen examination, obese parietes and a white scar. And at that time, I was an assistant professor. In the OPD, I examined it, and my obedient postgraduate was writing in detail, finding. I said that yes, pars speculum, cervix healthy, did a PV examination, said that you're right, uterus antivated, normal size, firm, mobile, fornix free. My curious postgraduate wanted to confirm it by PV examination as usual in the first year. I allowed She did the PV examination. Then she told, sir, I couldn't find anything. You have told that is antewater, normal size, fun mobile, phonics free, but I couldn't assess anything for that. Then I realized I also couldn't realize anything for that. In a 110 kg obese woman with previous 3 cesarean section, is it possible to find out and interpret as antewater, normal size, fun mobile and phonics free? It's just a guesswork. If it is not antewater, it must be retroverted. If it is not retroverted, it must be antewater. If nothing is found, you say that it is a normal size for that. I think it's just a guesswork for that. Then I realized that I have done a blunder in my life for that. Without properly assessing, I wrote that antewater normal size. And from that day, that postgraduate student has given me a lesson for that. And if the uterus is not felt properly by PV examination, from that day onwards till today, I write the size of the uterus not elicited. If I'm not able to elicit properly for that. If it is found, I write 10 weeks, 8 weeks, 12 weeks, 14 weeks, whatever it may be. If it is not found, I'm not able to find out anything, I better admit that yes, uterus size not being elicited for that. So what's wrong and what's right? No guesswork in gynecology for that. So no guesswork. If it is not retroverted, it must be anteverted. If it is not palpable, it must be normal size. Don't do that. Better admit that yes, with the imaging studies, we can know the size much better, and it happens. In clinical examination, in OPD, PV examination cannot give a really optimum amount of information as desired in all cases for that. Situation 3. Gravida 2 para 1, post-cesarean pregnancy, short stature, 38 years. This was when I was in periphery before joining a medical college teacher. Short stature, 38 years, cesarean section was done for CPD. With a healthy baby, female baby of birth weight 2.8 kg. Now, the report is there. Discharge report of the headquarter hospital was written that the indication was CPD. And now she has come with the second pregnancy, with the previous cesarean, indication written as a CPD. And now I examined a 38-year-old short stature. And now I find that is a vertex presentation. Normal fetal growth profile from the beginning ANC was done. And at that time, Johnson's formula, we used it and found out an estimated birth weight before delivery. This was 2.8 kg. And vertex presentation 5/5. And at that previous time, it was 2.8 kg baby was born. This time it was 3.2 kg. And sonography was not there at that time. Only the clinical sense was there. I did a clinical pelvimetry and apparently normal clinical pelvimetry. And I planned for elective CS on 28th of July. There is no wrong thing. I was not irrational in my decision. It was a previous cesarean section, short stature, and the cesarean was done for CPD. And that was obvious that I advised for an elective cesarean section. The date was fixed, but unfortunately, she went into spontaneous onset of labor one day before, 19th midnight, hospitalized, spontaneous vaginal delivery, male baby by midwife weighing 3.3 kg, without any maternal or fetal complications before I could reach. Then I was really confused. I have a doubt on my decision and our doubt of making a decision for cesarean section in this particular case. What is a wrong decision? Is it a wrong decision? What is CPD? Whether the C cephalic is defective or P pelvis is defective? No, D doctor is defective. I think the decision is important for that also. How to deal with such situation. Now, people say that obstetrics is unpredictable. Anything can happen. No. With the science, because of some lacuna, it is unpredictable. You have not analyzed properly. And here in this particular case, before decision making, two variables are there, scar and pelvis for them. And assessments is necessary, clinical assessment, biophysical assessment, and the clinical assessment, there are a lot of inaccuracies for that. And a clinical assessment of the pelvis by doing starting from the brim from the promontory to the curve of the sacrum, to the lateral pelvic wall, to the spines, interspinous diameter, and the outlet. You cannot assess that this particular baby or a head will negotiate through that pelvis or not. It's very important, or inaccuracy of estimation by the clinical pelvimetry. Although we write, our postgraduate say that sacral promontory not reached, side walls not divergent, it's divergent, and the ischial spine, the left ischial spine is prominent. I always see my postgraduate. Because they are prominent, they are called spines. Don't say the ischial spines are prominent. If it is not prominent, it could have been called a crest, right? Whether the SS, what is the interischial spinous diameter, that is more important. If that is short, you suspect that this pelvis is something abnormal for that. However, the inaccuracy, clinical pelvimetry of clinical pelvimetry gives rise to this problem for that. And obstetrician's bias, emotions, and luck plays a great role here. I always tell that permutation of combination of luck factor, lucky obstetrician, lucky patient, excellent prognosis. Unlucky obstetrician, unlucky patient, worst prognosis. Lucky obstetrician, unlucky patient, unlucky obstetrician, lucky patient, mixed prognosis in obstetric decision making is there. So therefore, what lessons I've learned in this particular case? Expect the unexpected. Many times you expect the unexpected. Assess and reassess. And therefore, pelvic assessment before pregnancy, before delivery, and after, during the process of delivery, birth, like in labor, you again reassess during labor for that. Even if you have assessed at 38 weeks, you reassess during labor. And second important, communication and counseling. I have counseled that this patient will undergo cesarean section because he's short stature, because he's 38 years, and because the cesarean was done for CPD. And therefore I told that vaginal delivery is impossible. You have to resort to a cesarean section. And the patient lost confidence on me. And I also feel very bad when the delivery has occurred, because the communication and counseling, I should have been more diplomatic in that way. Because of inaccuracy of assessment, I should have told that yes, again I will assess during the labor, and decision of the labor is there, but the elective cesarean section is justified in this particular case. And learn from others' mistake and gain from your mistake. I learned one thing, that within so many years, I've done a number of mistakes for that. But if I'll do a mistake and learn from my own mistake, whole life will be spending on doing mistakes and learning. I should gain from your mistake and learn from other mistake, and do not do the same mistake, so that in this lifespan I can do something for them. And lastly, I can say, any mistake you do it, think about it seriously. What I have done and what is the cause, how I will not do in further mistakes, learning from this, and introspection is essential for that. If introspection is not there, you say that in obstetrics this happens, it is unpredictable, then it is an end stage. It is a full stop in that. You don't develop your own ideas for that. So introspection, if there is any failure or any mistake, you introspect so that you can improve in subsequent cases. Situation 4. Mrs. X, 48 years with heavy menstrual bleeding for last 3 years. Para 2, both LSCs, and uterus 16 weeks, endometrial biopsy, simple hyperplasia for that. And simple hyperplasia, sonographic evidence of multiple myoma uterus with cholelithiasis, having multiple calculus. Planned for combined surgery for lap call and hysterectomy in single sitting for that. Now, this combined procedure or a joint procedure for that is nowadays we are taking when the minimal concept of minimal invasive surgery has come out. And therefore, it is better beneficial for the patient doing the same 2 surgeries in the same sitting for that. Lap call and hysterectomy in a single sitting. And I asked my general surgeon, and the general surgeon came, and we had planned that. When the general surgeon came, he told that I will have some work. I will do the lap call first because of my commitment. I agreed to it. And lap call was finished and during the time of tissue retrieval of the gallbladder, patient had an intra-op cardiac arrest. Hysterectomy was postponed. Luckily, patient was resuscitated and revived and sent to the ward and discharged from the hospital after complete recovery after 3 days, but with the diseased uterus in situ for which she had visited me. It's most unfortunate. The primary complaint is a myoma uterus with heavy menstrual bleeding. Incidental finding was a cholelithiasis, but the cholecystectomy was done and the diseased uterus was left behind. So therefore, what lessons I have learnt it for them? Combined surgery for 2 pathologies in one sitting is not contraindicated. In the era of minimal invasive surgery, such procedures is beneficial to the patient. But the principle should be take up the surgery first for which the patient has presented, not for the coincidental findings. This I have learned. And subsequently, wherever I am doing a combined surgery, the purpose for which the patient has been consulted, if the gynecological problem is first, do the gynecological case first. And surgical case is first, gynecological is an incidental finding, do the LabCol first and then incidental finding. That I remembered and following till date. Primary gravida, 32 years. Conceived following investigation for primary infertility, 8 years. IVF conception. Husband is an IPS officer, wife is a journalist. Terrible combination. It is a twin pregnancy, irregular ANC, had bleeding at 10th, 11th week. Treated conservatively, NT triple marker normal. And at that time we are doing a triple marker. Nowadays we are doing an IPS. TIFA was normal scan, normotensive, admitted with preterm labor at 31st week. Hospitalized, given betamethasone, nifedipine, rest, repeat sonography revealed normal biophysical profile. Discharged after 1 week, counseled to undergo elective CS at 34th to 36th week. Readmitted after 2 weeks, 34th week, she was readmitted with again an episode of mild bleeding PV. BP was 140/90. Uterus tense, tender, FHS not localized, no active bleeding PV, urine albumin index. Luckily, I have, during the time of discharge, I counseled him to come every week. And if the patient, fortunately, the patient was consulted and she failed to come within the next week. And after 2 weeks, she came. And by the time she came, FHS were not localized. BP was 140/90. Sonography twin fetuses at 33.2 and 34.1 weeks. IUFD bivortex. Estimated birth weight was 2.2 kg to 2.4 kg. Placenta upper segment, no evidence of retroplacental clot. So what's wrong with the patient? Wrong with the patient is that she was regular up till about 31 weeks. But then subsequently when the problem started, in spite of my advice, she failed to come up every week for that. But what's wrong with the obstetrician? I analyzed what defect I have done it for that. First, the patient gave, the fetuses gave an alarm signal at 11 weeks with bleeding PV, spotting. Second alarm signal with the preterm labor at 31st week. This is normal in a case of twin pregnancy and is absolutely continuing for that. And I have advised for to come as a periodic checkup. And in this particular case, I have decided that I will not go up to term 37 is well and good. That's good. But wrong decision of interference at 36th week. I analyzed that it is wrong to do cesarean section or interference at 36th week for that. Because the patient came with 34 weeks also she came and the blood pressure was 140/90. And that particular moment, even with mild hypertension at 34th week, the fetal survival is up to almost around more than 95% to 96% with a minimal neonatal care for that. And therefore, no more 37 weeks for that. In this particular type of risk cases, you just target from in between 34 to 36 weeks, you terminate the pregnancy. And more so when the alarm signal is there for that. And therefore, this is a wrong decision of mine, and subsequently I decide in such extremely valuable pregnancy for that, with alarm signal for that, I'll be more liberal in doing the intervention at around 34 weeks. And this is a cutoff limit, not 37 weeks is a cutoff limit for that. Not necessarily all IVF pregnancy you deliver at 34 weeks. Remember this. I'm not giving a message that don't do cesarean section at 34 weeks or termination of pregnancy at 34 weeks for that. But whenever there is some alarm signal, whenever there is some problem like a mild, even if it's a mild hypertension for that, keep a watch for that. And early intervention will give a benefit for that. And nowadays, the fetal survival is optimum at about 34 weeks for that. So 34 weeks is a cutoff limit for that, below which it might need for a neonatal intensive care facilities there. But with minimal facilities, minimal standard of care, the babies, 99% of the babies can survive at 34 weeks for that. What could have been done to save the babies or baby? I think early interference is done, which I had done a mistake though. And what next is $1 million question. So the message lesson learned, IVF pregnancy is luck, but to have a baby is destiny. Even with best practice, such things can happen. Prevention and prediction is $1 million question for that. And early intervention is justified, but only on retrospective thought. Counseling, communicating bad news and after effect is important for that. Next pregnancy possibilities is a big $1 million question, and outcome is $1 million question. Situation 6, Gravida 3, Para 2, Placenta Previa. Previous cesarean section, transverse lie at 36 weeks, LSCS was done. Indication wise, it's absolutely normal. Post-cesarean pregnancy, placenta previa, and a transverse lie. And a male baby of 2.4 kg was delivered with difficulty with fracture left femur of the baby, not of the obstetrician, and lateral extension of uterine incision with broad ligament hematoma, uterine atony, PPH, shock, patient resuscitated and saved. Now, two questions comes as an introspection. How to prevent? Is it preventable? And if it is there, how to manage for that? Now, prevention. Very important is that as a surgeon, either an obstetrics case or a gynecological case, majority of us do not have a pre-op planning. Remember, I learned from this particular case that pre-op planning is absolutely necessary for that. Before putting a knife, I must analyze what are the cases, what difficulties I should get in this particular case, because it's a post-cesarean section, it is a transverse lie, it is a placenta previa. All the three risk factors are there, and therefore I should mentally be prepared, and in my mental mindset, I will have a mindset of a pre-op planning. Because invariably we find if there's a transverse lie, we must find out what side, what is the side of the head is there, and what is there, where is the leg is there, so that I will not introduce my hand and pull down the arm. I will introduce my hand where the leg is there to the right side and bring down, rather than moving all side in the uterine, either on the left or right, and having a guesswork for that. So this is pre-op planning. A post-cesarean expected to have an adhesion, expected to have a bleeding during surgery for that. This is another thing. And more so when there is an APH placenta previa, and more so I must find out whether it's an anterior placenta previa or a posterior placenta previa. Complete central or incomplete central by sonography. And therefore, if it is a posterior placenta previa, it is much favorable for that. If it is an anterior placenta previa, I think you must be very, very cautious about prevention of bleeding for that also. So identify the risk factor: post-cesarean section, placenta previa, malpresentation. And of course, in this particular case, both traumatic as well as atonic PPH are likely to occur for that. So here lies the experience. The surgical expertise is necessary for that in these critical situations for that. And these are preventive surgical steps should be taken. Tackling vessels before incision. If there is a vessels, if there is a placenta previa anterior, the vessels are there in the lower uterine segment. You don't incise it before ligating proximally and distally. You just put a ligation there. U-shaped incision on the uterus is better because it's an elective cesarean section. U-shaped incision will avoid the involvement of the uterine artery in the lateral angle for that. And of course, the gentle delivery of a baby for that. A very good gentle delivery of the baby. Don't have a gymnastics in the OT for that also. Don't put your hand and here and there you find out and try to find out the legs and bringing down the legs instead of you bring the arms for that. And prophylactic ecbolics. A good ecbolic should be given in the right time for that. And I always say in cesarean section to my students, 3 P's you follow. You deliver the baby and then don't do a manual removal of the placenta to save few minutes time for that. Then you ask a pack. Don't apply the pack before then. You just deliver the baby, give an ecbolics and a mop on the uterine edges for that also. Temporary pack, press and pray. 3 P's you follow and remember this 4th P, Pisimapa. And allow the placenta to separate by own spontaneous separation rather than manual removal of the placenta for that. And of course, active management of 3rd stage. Recognize the active bleeders, tackle separately. Normally what we do in angle, suppose there is a bleeding, along with the bleeding, along with the artery, along with the muscle, you take in the same bite and there is a puncture and there is a bruise, there is a hematoma, you just retract it, again blindly put it in the lateral aspect, again big hematoma on the uterine artery. You are visible, artery is visible, you must ligate the artery from below and from above and then start from the apex for that. Recognize active bleeders and tie separately for that. And optimum hemostatic closure is necessary. I think hemostasis to the surgeon and oxygen support to the anesthetist. If these two are followed up, no intraoperative mishap will be there for that. And then peripartum monitoring, you do it. Situation 7. Primi gravida, 38 weeks in labor, planned for emergency cesarean section due to non-progress of labor. Way back about 25 years before, in early 2000, 2001, this was the case. Delivery of the baby done with classical gymnastics. At that time, we are doing it. We are being taught like that. You introduce your hand, go below the head, and remove it, and just remove it, and simultaneously ask your assistant to give a fundal pressure. The assistant fails, ask the anesthetist, ask the pharmacist. 3-4 people will be giving a fundal pressure in the OT. I believe that it's a classical operative gymnastics. And after delivery, what happens? Extension of the uterine wound on left side involving the uterine arteries, extension of the lower uterine segment on right angle, and colporexis on one side, repaired with difficulty, lot of blood loss, traumatic PPH, 2 units of blood transfusion was given for that. Then I introspected. Then I analyzed what was the problem, why this happened. It's a wrong delivery of the baby. There should be a procedure of a right technique of delivery of the baby. How to prevent, by that we can prevent it, and how to manage. If the bleeding occurs, then the manage occurs. But primarily is the preventive obstetrics. And therefore, then subsequently, I analyzed the right technique of delivery of the baby is important. And at that time, many of our teachers, I learned that they were applying forceps for that. And that was more mainly for high head. Delivery of the high head during cesarean section forceps. Now, if you apply forceps, the most important part is that right application, cephalic application is never possible. It is just again a guesswork for that. And therefore, many times you fail, then one blade, you say there is the vactis which is there, and then there is a chance of corn fracture. I have seen corn fracture of the baby skull for that by using a forceps. So I was not happy with the forceps for that. Till I get a Celastic vacuum. At that time, the Malmstrom metallic vacuum was there, which we are using it during vaginal delivery. But when the Celastic vacuum came, I thought I will use this particular case in all heads during delivery of the cesarean. If head is there, either a low head or a mid head or a high head, whatever it may be there, the delivery will be by the vacuum, middle size vacuum for that. and therefore operative gymnastics will be avoided, and the extension to the lateral angle and extension of the tear of the lower uterine segment will not occur for that, and that's a fact for that. And for the last 25 years, I've adopted this principle and teaching my students and all my students also using this particular situation by vacuum for that, and they are very happy about it. This is the way how you use it for that. You just apply the vacuum, and the whole vacuum cannot be applied over the scalp, half to the scalp and half over the cutters of the, I think, the lower uterine segment for that. And then with the finger, you roll out and find out all the things for that, so that the lower uterine segment, the edges will recede and the whole vacuum will be grasping the fetal scalp for that. And here is a very well without with minimal pressure, even no fundal pressure, this can be delivered very easily for that. And I'm practicing since last 25 years, and my students are also doing the same procedure. And after that, you find least extension to the lateral wound. Uterine is least involved for that. There is no additional tear for that, and that's very good for that. So this is the lesson which I learned from my own mistake. Situation 8. Gravida 3, para 2, L1, previous 2 CS. First was cesarean section, torn male baby, could not be revived. Second, LSES elective, female baby of 2.9 kg, living 6 years. And third is my torn. The patient came to me on third pregnancy, and she was not conceiving. She conceived following investigation for second infertility. I did a tubal cannulation with a regular ANC. Third gravida with 2 previous cesarean section with 1 living issue. Irregular ANC, no risk factor, normal biophysical profile, even color Doppler was normal, and therefore decision for elective LSAS on 18th February, date has been given. At 38th week, I decided for this cesarean section, elective cesarean section. And she agreed, and after the next day, the mother-in-law came and requested and opted and wanted to change the date and fixed a date as advised by Baba. Some Baba in the house advised, instead of 18th, you fix on 20th of February, just 2 days. And I've done almost around color Doppler, ultrasound, biophysical profile, everything is normal for that. There is no risk factor, normotensive. Only thing is that she lost 1 baby in the first cesarean section. So I easily agreed because there is no technical problem for that. But God has behaved something opposite. He took revenge. On 19th of February, not on me, but on the Baba. 19th February, patient had 1 episode of bleeding PV, uterus relaxed, normotensive, FHS not localized, sonography demonstrated IUFD. I did a cesarean section, but a fresh stillborn baby, and I found the cause of death is a true knot. I think this cannot be prevented, but a true knot in the card I found out for that. But what is the comments? What's wrong with the obstetricians? What's wrong with the patient? This is an accident. No doubt this is an accident. But accident can happen. But it's coincidence which is more painful for the obstetrician. And therefore, decision versus deviation. Since that time, I had made a principle that if I decided a fixed up a date, I will not deviate for that. Even a patient comes with a previous cesarean section and given a date, elective cesarean section, previous cesarean section, gravida 2, para 1, L0, and previous section, no living issue. A patient has a mild pain, admitted to 12 midnight in nursing home for that. In a 12 midnight, she was admitted for that. She's not having a pain, fetal heart is good, and my staff told that everything is normal, normotensive. Patient is having a mild contractions for that. But she has been advised to do a cesarean section 3 days after. So 3 days before she had a mild pain abdomen, she was admitted for that. And after all these, my past experience of failure for that, I said that even if there's a mild contraction, I will do in the dead of night rather than waiting for the whole night so that I can sleep and you can sleep. In the morning, we could have done it for them. But some mishap can occur in that particular time. If the decision has been given for cesarean section, patient came with some complaint, do it in the whole night, that night also for that, if a decision is there. So this I make a philosophy after this mistake I've done in my life for that. Situation 9. Again, when I was a postgraduate student, first year, a patient came, delivered in my labor room, para 1, with jaundice, viral hepatitis, and this was again in 1980s. Viral hepatitis, delivered a torn female baby by vaginal route with mediolateral episiotomy with a mild PPH. It was controlled with Aqualex. At that time, Methergine we are giving it. Had continuous trickling of blood following delivery. Coagulation profile was normal. Uterus contracted, vitamin K given, blood transplant 3 units was given. But still, mild bleeding PV continuing. And on second day, my professor gave a round in the labor room. Professor told that yes, in viral hepatitis and jaundice, bleeding happens. This was the norm. This was the dogma there. Professor advised hematological profile repeated, normal. Advised for a vitamin K repeat dose. Then advised some of the empirical company has promoted this injection Batropas and give a Batropas and blood transplant to continue. And we continued. Then at that time, we are postgraduates. So after 2 p.m. on emergency hour, you can decide. Before 2 p.m., your senior will decide for that. So after 2 p.m., I was curious about this case. I wanted where from the bleeding comes. Then I asked, they say that yes, in jaundice it happens, bleeding occurs and all that. But I asked my staff nurse, bring a speculum and I must see where is the bleeding coming from, the uterus or something else. So when I found, examined the patient, putting a speculum, I found a small bleeding point in the apex. I put a stitch without informing anybody and bleeding was immediately controlled. Patient stable, absolutely dry. The patient was bleeding for the last 1.5 days and 3 units of blood has been given for that. And the next day, the professor came to the round and told that, see how Batropas acts for that. But my RS knew that and he conveyed to the professor that no, yesterday this postgraduate has done a speculum examination, there was a bleeding and put a stitch and bleeding has stopped for him. My professor felt ashamed for that. And he called me in his room and he appreciated my effort and said that I'm very happy with you today. I told, sir, be very happy with me during my MD examination day, not today for that. If you're happy, pass me in first chance for that. Of course, I passed in first chance, but patient had an uneventful recovery. But what's wrong? It is a fixed idea, dogmatic views and complacency. This is the result of that. You don't have a fixed idea is that in jaundice bleeding occurs. It's a fixed idea and it's a dogmatic view. Only vitamin K you continue and blood transplant you continue. So prefixed idea is fatal in medicine. I have learned that. And methodical treatment has its own place. Go methodical treatment for that. And one has to learn from anybody. You can learn from your staff nurse, you can learn from your class 4, you can learn from many your students or postgraduates or even undergraduates also you can learn for that. Situation 10. 23 years, para 2, vaginal delivery, full-term male baby, Apgar score is 8/10, had severe PPH after delivery. Egg polyps was given, blood transplant arranged, bleeding continuing, vitals falling. And my assistant professor in the labor room decided for emergency hysterectomy. And at that time, I was doing a hysterectomy on my routine OT on the other side. And in the emergency OT, she did the hysterectomy for them. And hysterectomy was performed within no time, but bleeding continuing. And therefore, she asked me, sir, you come and help me. Bleeding is continuing even after doing a hysterectomy for them. So I left my surgery and when I put a speculum, I find revealed a lateral vaginal wall tear with active bleeding. I sutured it. Patient had a cardiac arrest and could not be revived for that. And I think is a bad luck of the lady. No, it's the bad hands of us, the obstetrician, for that. And the message and lessons learned is that all PPH are not supposed to be atonic. That's a presumption only. Brain should be active while hands are hyperactive. And had it been there, detected, put a speculum in the labor room itself, I think, and stitched in the labor room, the lateral vaginal wall tear, the uterus would have been saved, the patient would have been saved for that. It's a wrong decision for that, and guidelines has to be followed. And introspection for future is required. Don't presume that all PPH are atonic. I think this is a methodical examination should be done. You rule out atonic and as well as a traumatic PPH for that. And there's an introspection for future is required. And don't blame the luck, blame myself for that. And there's a mistake which I've done it for that. Mrs. F, primary infertility, 5 years. Planned for diagnostic hysterolaparoscopy. And you find this is the picture of the hysteroscopic view. A patient came with 5 years of infertility, diagnostic hysterolaparoscopy was done, and when I put a hysteroscope, I found something unusual in the cavity for that. And when I found this space-occupying lesion, and this space-occupying lesion is nothing but the intrauterine pregnancy sac with the embryo in situ, with just an injury because of the scope for that, and little oozing for that. All around, clearly we can find a gestational sac with the embryo for that. I was really ashamed. A patient came with infertility for 5 years, and then this is the situation for that. And therefore, immediately abandoned the procedure. Instead of evacuation, I prayed God. Tons and tons of progesterone I added. I added intramuscular progesterone, subvaginal progesterone, and everything which is possible for that. Tons and tons of progesterone, and tried to conjure the pregnancy for that. And fortunately, pregnancy continued, and uneventful antenatal and intrapartum period. Male baby now doing well, 4 years. God is great, and this is a miracle. Miracle happens at times, not always for that. But what is your defect? And that time, I think only thing is that I have lost. The last menstrual period is about 10 days back. But if there is a suspicion, always ask last normal menstrual period. It's not the LMP. LNMP is important for that also. And you say 5 years he was not conceiving, and once he has come to see me, and at that time pregnancy was there, and I did an investigation, I did a DHL, knowing fully well that the last menstrual date was in 10 days back. Since that time, I always tell last normal menstrual period. If it is scanty menses, you review. If there is a suspicion, you do a pregnancy test. You do a beta HCG for that. So these are the cases. It's not very unusual for that. Mrs. X, case of RPL, plan for diagnostic hysteroscopy and cavity evaluation. And some of my fellows did that and found that, sir, come and see the complete uterine synechia, and wanted my second opinion for that. And he see the picture of that. This, you put it a synechia. I told that it's a synechia. It doesn't appear to me as a synechia for that, because at 12 o'clock position, you find some halo, some black space for that, black halo for that. I found everything details. It's not a case of synechia. I told that just depress your telescope, hysteroscope down and see what is there above, and go above, not here in this particular case for that. And when we go above, we find a nice uterine cavity, a normal uterine cavity here with the 2 osteum on either side. It is never a case of synechia. A lot of cases I find being referred, that synechia for that. This happens. This is not a very unusual situation. Don't blame anybody, because at this age also, I fail to dilate in some cases for that. Dilatation becomes difficult in some cases and all that. And therefore, what is the situation done for that? And therefore, this is a false passage. Now, how to prevent the false passage is important for that. How to recognize is important. If this is done, I learned it from this lesson for that. And then I found out the dilatation. If you can avoid a dilator, without a dilator, if you can do it, if it is good. And if it is, you are applying a dilator, facilitate the dilatation with some other agent for that. These are the two options in my side for that. And therefore, this is a vaginoscopic hysteroscopic evaluation for that. You just go vaginoscopy, and here a small telescope is usually needed. Instead of a classical 4 millimeter, you use 2.9 millimeter telescope for that. And to identify the cervix, the external os, negotiate with the external os, follow it under vision, go through the cervical canal until you find the black hole in the upper part, and then negotiate gently to get the whole uterine cavity beyond the internal os. And this is the brilliant uterine cavity, normal uterine cavity, panoramic view with the two osteum on either side for that. This is one option. That you can do a small dimensions hysteroscope, or just a single channel you can use it for that, or some other agent to facilitate for that. So what is the how to prevent and how to manage for that? Management in this particular is not a false, it's a false passage, but it's not a perforation through and through. So don't do anything, don't interfere anything for that. But to complete the procedure for that, management is not important. If there is a perforation, you have to interfere with the laparoscope for that. So what is the message we learn? Improper dilatation is the factor for that. And visibility and orientation, change of direction of scope, double channel sits, and gentleness with negotiation without resistance is the key. The technique of proper dilatation is important for that. And therefore, don't force it properly. Just negotiate the dilator. Go to the proper place, either anteverted or retroverted. All uterus are not anteverted or retroverted. There could be lateral shift also, either deviated to the right or deviated to the left also. So find out with the gentle negotiation of the dilator, you can be possible. And if there is a resistance, don't push forward for that. And therefore, the second option is that pre-op vaginal misoprostol is a unique molecule, misoprostol. Is used in obstetric practice, but this is a very good thing. I love this molecule. 400 milligram misoprostol, 2 hours before surgery intravaginal, you put it for that. And it will really facilitate the procedure. Even dilatation is not necessary for that also. In cases where there is a previous difficulty, this is a mandatory thing, but routinely you can use the misoprostol pre-op also. It is mandatory for all therapeutic hysteroscopy, I can say. All therapeutic, whether if you are doing a therapeutic hysteroscopy, either a septum or a synechia or a case of myoma or a polyp, you have to use this misoprostol. I particularly use it routinely in all cases. And in all primary infertility, if you are doing a diagnostic hysterolaparoscopy, you use it, that will be easy for that. Dilatation will not. But the only problem there will be there. That chromoperturbation, when you do it, there will be a backflow from the cervical side. So that even the patency is there, you find that yes, dye is not spilling outside. This is the only problem in some cases we find in the DHL for that. And here you change your HSG cannula for that. You charge the chromoperturbation cannula gradually thicker and larger. The cannula is necessary for that. By that you use it. That will solve the purpose. This is a case, a para 2, previous cesarean, previous history of myomectomy, presented with abnormal uterine bleeding, not responding to medications, and uterus was 12 weeks with myoma uterus. And I planned for a vaginal hysterectomy. I was over enthusiastic. I love a vaginal surgery. Instead of doing a lap hysterectomy. In this particular case, I can say that 12 weeks mobile uterus. Only thing is that history of myomectomy there and a previous cesarean. And the previous cesarean, the technique is the lateral window. You always go to the lateral window because the injury to the bladder is most often there for that. And therefore, you go through the lateral window on either side, then come to the center. Things will be absolutely okay, even if there are previous 2-3 cesarean sections. That is the mantra. Now, myomectomy, the adhesions will be up in the fundus and beyond. And therefore, in the last part, you take care to find out any adhesions and gently find out and avoid adhesions of the bowel for that also. But in this particular case, I completed the procedure very easily. I did this hysterectomy. And while giving a suction, I find a brinjal seed. I didn't find a fecal material. The brinjal seed is found. So I become suspicious. Why from the brinjal seed has come to the pelvis? I searched very meticulously and I find a small injury in the rectosigmoid of about 0.5 centimeter. No feces are coming because the patient was prepared well for that. And therefore, it was ignored for that. And a small 0.5 centimeter rent was detected. And I repaired it from the vaginal part, same site for that. And I repaired this particular case and completed the procedure, and the vault was closed for that. And patient has an uneventful recovery for that. So this is how I did a mistake, but I learned from my mistake. Rectosigmoid injury can occur in vaginal surgery for that. The detection is very important. Detection is vital for that. And repair in the same sitting is feasible. And it depends on the length of repair, on the number of injuries they are there for that, whether the edges are clean cut or ragged. If there's a long set of injury, more than 5 centimeter, I think it's a clean cut. It's not a clean cut injury and a zigzag injury and a lacerated injury on that. I think these are the cases you call the surgeon for the diversion. Otherwise, majority of the cases you can repair then and there in 2 layers and then manage postoperatively and things will be all right for that. So meticulous technique is the answer for that. 38-year-old, history of progressive dysmenorrhea since menarche. I cannot forget this particular patient. Laparotomy was done at the age of 16 years for bilateral chocolate cyst ovary. Relayed for 6 months only. Taking analgesics off and on. Married at the age of 20. Investigated for infertility. Laparoscopic surgery at that time was there. And then laparoscopic surgery twice was done. Persisting pain, ureteric stenting was done for the ureteric involvement of hydroureter. And 3 sittings was done. Persisting pain and infertility, IUI 6 sittings, IVF 3 sittings. Tons and tons of progestogens, danazol, GnRH analog, Depo, Provera for years. And presenting with severe pain with adenomyosis and chocolate cyst ovary with it. At that time, no new molecule as we find now was found. And at that time, GnRH antagonist was not there. And even Dynogest was not there. And planned for laparoscopic hysterectomy. When I think these are the cases, patient has adopted a baby and laparoscopic hysterectomy, she was so keen for hysterectomy because of the pain that at the age of 38 years, I did a laparoscopy. When I put a scope and tried to find out whole pelvis is plastered, I couldn't identify any organs, neither the uterus nor the adnexa. The whole thing was plastered along with the gut. I attempted from the lateral window. From the lateral window, I dissected, but I failed to dissect that. Then I didn't have any ego. I usually did a conversion and an open hysterectomy. I did it. And fortunately, at the age of 36 years, hysterectomy with bilateral salpingo-oophorectomy could be done by laparotomy. And she was relieved for symptoms for 6 months. After 6 months, she developed again severe dysphagia with pain in right iliac fossa. On examination, endometriotic nodule in the vault and postofornix with cystic lump in the right fornix. Sonography revealed a residual endometriotic cyst with evidence of vault endometriosis, not relieved with medical management, from Pati to Pati, from Pasupati to Tirupati, from Babas to Mamas, attempted suicide twice. Endometriosis is not leaving her, starting from the menarche till 38 years. And she tried to commit suicide, but the supportive husband rescued, and both of them came. And to me, what next? I wanted to do a decided for surgery because it's a failure of all medical management. Decided for surgery with colorectal surgeon. Excision of the cyst and rectosigmoid lesions with ureteric dissection with stenting and colostomy was done. And we removed the part of the gut which is involved with the colostomy, with the endometriosis, and did a colostomy. Then the surgeon friend told that I will do a closure of the colostomy after 3 months in my own unit. She was comfortable, but she admitted after 3 months to the surgical unit. But unfortunately, she died on 4th post-op day due to blood transfusion reaction. It was really painful for me. She died due to blood transfusion reaction. It's an unlucky patient. I am an unlucky gynecologist. Born with pain and died with pain. And I couldn't do anything for that. The preventable death, 1 unit of blood can easily take life, and it cannot save life for that. So the message and the lessons learned: restriction of perioperative blood transfusion. I usually limit blood transfusion in the era when parenteral iron was very effective. You build up the patient with parenteral iron. Don't build up the patient with blood transfusion unless it is indicated in acute emergency or in a malignancy. I think restricted use of blood transfusion is mandatory. That I learned. Preoperative planning and preparation should be done. And 1 unit of blood can easily kill a patient. Those require blood, they require more than 1 unit. And transfusion phobia, benefit versus risk. This 45-year-old para 2, both LSCS, known case of pelvic endometriosis with adenomyosis, previous history of lap surgery once, and laparotomy once. Hysterectomy could not be done, and refer case with persistent pain and bleeding to me. I planned for each surgery after 6 weeks. Hysterectomy with bilateral sulping oophorectomy could be done in spite of plastered pelvis and non-visualization of anatomy, but the left ureter was avulsed, detected immediately, and then ureteric implantation to the bladder done, and post-operative period was uneventful. I think this is a very important. The detection is important for that also. And the patient has a very good uneventful recovery after putting a DJ stent for that, and DJ stent has been removed 6 weeks after the procedure. And this you learn from a urologist, and the urologist will teach you this particular technique for that. Bladder injury, you do repair yourself. But ureteric injury, ureteric implantation, I think it needs the help of the urologist for that. Some cases I found, even during the laparoscopic procedure, I have injured the ureter during the laparoscopic procedure, and I detect that even that particular case, even if I do a lateral pelvic wall dissection, is always when there is a absolutely in a TO mass buried to the ovarian fossa and residual endometriotic cyst following hysterectomy. These are the cases where ureteric dissection has to be done for that. And in 2 of my cases, even if I did a ureteric dissection, there was a hydroureter, and beyond which the ureter was very thin for that, and that created a lot of problem for that. And for the hydroureter, immediately there is we do either deliberately, you cut the ureter and implant it to the bladder, or if at all you cannot, you can do it for that, and thinking that the ureter is thin and you can repair it for that. And if the avulsion is there, you find out, and then laparoscopically the uretero-bladder anastomosis can be done, and post-op period is very, very good for that. So the message and lessons learned: ureteric injury, real panacea for gynecologist. Preventive surgical technique is mandatory. Learning cystoscopy, ureteric catheterization, and ureteric implantation is a must for gynecologist. I think this is important, that the anterior partner and posterior partner should not be an enemy for you. It should be a friend for you, and you should learn from the urologist and do it yourself, building confidence in pelvic surgery for that. This is a case where I showed that yes, this is a bladder injury. Bladder injury can be repaired in layers, and but the bladder either during cesarean section or during hysterectomy. The rule applies. Start from the lateral window. In vaginal surgery, we say that but in abdominal also, in laparoscopic also, when we're doing a DLH, start from the lateral window. On either side, up to the center, you will avoid the bladder injury in almost around 99% of the cases. This is again a case when before my medical college, in the periphery, I was a specialist. Way back in 1982-83. Mrs. X, primary gravida, came with a deep transverse arrest and planned for emergency LSS under local anesthesia. I think I was doing in the CHC. I did this case under local anesthesia. And baby delivered, and the mother had severe hypotension, bradycardia, and cardiac arrest. I did a cardiac massage, pressure agents, hydrocortisone given, and patient could be revived. And as a surgeon, I tried to finish the surgery as fast as possible after resuscitating the mother for that. After doing a cardiac massage, resuscitated it, BP pulse is normal. Then I tried to finish the surgery as fast as possible. And that's why I did a single layer closure of the uterus. Patient could be resuscitated on eventful recovery for them. When the concept of single layer closure came 20 years after, I thought it was my first case. Without realizing, I did this for the purpose of the cardiac arrest for that. And subsequently, I said that yes, it is for emergency, for the life-saving situation is important. Otherwise, there are much benefit of doing a double layer closure, and I have never done a single layer closure. After doing initial 50 cases, studied it, compared it, and find no difference, I again switched over to the 2-layer. So such surgical complication is not uncommon. Managing the surgical condition as well as completing the surgery during crisis single-handedly is really a challenge. And concept of singular closure, my personal experience, long before 2 decades before the emerging concept came. This again, gravida 2 para 1 post-CS pregnancy, presented with impending rupture uterus, laparotomy was done, moderate hemoperitoneum, dehiscence of scar, asphyxiated male baby delivered, could be resuscitated. Repair of scar with hemostasis was done, peritoneal toileting done, uneventful intra period, requisition for blood given, a standby. And on second day, hemoglobin was 7 gram, patient was stable. And for the patient's party, run after me for giving a blood, because with the difficulty we have brought about blood, and you must. I said that blood can create problem for them. I don't want to give blood with a stable patient of 7 gram. But patient's husband insisted for blood transfusion, and the staff gave it. 1 unit of blood transfused, severe blood transfusion reaction, hematuria, shock, and patient died after 12 hours. So therefore, this is again a second, in addition to my first case, restrict blood transfusion, preoperative, intraoperative, and postoperative, unless it is absolutely mandatory, like an emergency situation, patient is bleeding, it's a case of the past disorder, doing subtotal hysterectomy, and the patient is bleeding, and malignancy in a case of gynecological case. These are the cases you build up with that blood transfusion. And not 1 unit, multiple units of blood are needed for that. So 1 unit of blood can kill a patient. 1 unit of blood cannot save a patient. Those require blood, they require more than 1 unit of blood, and restricted blood transfusion is to be done for that. Mrs. X, 96 kg, previous CS with mama uterus and cholelithiasis, planned for lap hysterectomy with lap call. Again with the surgeons. Uneventful intra period, Third post-op day, patient had breathlessness and chest pain, tachycardia and tachypnea, decreased SpO2, transferred to ICU. Diagnosed as pulmonary embolism, ARDS, hyperinized, could be revived after 10 days of hectic stay in ICU for that. And such things are not uncommon. People say that it's a amniotic fluid embolism. It's a pulmonary embolism, but that's not. It's a pulmonary embolism, could be pulmonary embolism, and so-called amniotic fluid embolism is rare to be confirmed for that. And therefore, role of prophylactic. From that day onwards, my philosophy is that I will give a preventive low molecular weight heparin. Prophylactic LMWH routinely when the weight is more than 90 kg. In any surgical patient, in any obstetric patient or gynecological patient, 90 kg, more than 90 kg, routinely for 3-4 days, 60 milligram or 80 milligram, 80 units daily for 3-4 days you give perioperatively. And you prevent this thrombophilaxis. If you give it, you prevent this fatal incidence of embolism for that. So this is pulmonary embolism, could be prevented that. And quite few cases I have seen that. So indication from that day. I always say for 5 days perioperatively, all patients with weight more than 90 kg. Prolonged period of surgery more than 2 hours. Radical surgery. These are the cases, and pelvic surgery with a prolonged duration. This routinely is a mandatory to give a 5 days therapy as a prophylactic, about 80 units every day for 5 days. Mrs. X, 52 years, para 2, multiple myoma, 14 to 16 weeks, planned for vaginal hysterectomy. And again, it was performed successfully, discharged after 3 days, uneventful recovery, presented after 7 days with passage of fecal matter to the vagina. I was shocked. On examination, I examined it. Patient was stable, afebrile, and palpation of abdomen. Abdomen is soft, bowel bladder normal movement. And when putting a speculum, is a rectovaginal fistula. So I didn't interfere. Sonography, I did a sonography, no intra-abdominal collection, and decided for surgical intervention if altered abdominal signs or after 3 months. I decided that I will not do anything. If I find altered abdominal signs like distension, then I will intervene for that. So I put in conservative management, and I found that yes, stayed in hospital with observation and antibiotics. She has been admitted in some other corporate hospital. They decided for doing the exploratory laparotomy and then and there for that with the surgeon. And the patient came down and took my advice, and my hospital, she came and I took it, I admitted the patient, and after 3 days, discharged, reduced. Discharged from the hospital with counseling to have checkup after 2 weeks and for future surgical intervention. Came after 2 weeks, Helena T, no discharge, abdomen soft, bowel bladder normal, perspiculum valve healthy, no discharge. Don't think that is a miracle. I think this particular case, a gut injury during the procedure, post-operatively, find one thing. If the patient general condition is fine, if the abdomen is soft, and leave it as such, have a conservative management for that. Automatic. That means the fecal material or the sac is not connected to the peritoneum. If it is sealed and in a separate cavity it is there, automatically it will heal for that with spontaneous healing. If the patient doesn't improve after surgery, more so after minimal invasive surgery, you have done a laparoscopic hysterectomy or a vaginal hysterectomy, and the patient should improve day by day, hour by hour, minute by minute. If the patient doesn't improve, then think seriously for that. And if the abdominal signs are there, distensions are there, then you intervene. Otherwise, conservative management is the rule for that, and God will help you. That I have learned it. God is great. I am a lucky surgeon, she is a lucky patient, and therefore the place for conservatism is there. Para 2, 46 years, both LSCS for AUB, not relieved with medication, planned for lap hysterectomy. Lap hysterectomy was done, dense adhesion of bladder was there, successfully performed. Uneventful post-op period, discharged. Presented with urinary incontinence after 10 days, diagnosed, did a cystoscopy, and I found there is a PVF, it's not a ureteric fistula. And therefore, I put again a Hollis catheter for that, and I planned for the repair after 6 weeks in consultation with the urologist for that. Indwelling catheter was done for 4 weeks for that. And catheter removed after 4 weeks, urine leak persisting along with normal voiding. Voiding was there, but along with that, urine leak was consistent. So again, I continued that advised to come after 2 weeks for repair for that. Advised to come after 2 weeks. Again, I put a catheter and asked that you come after 2 weeks. And fortunately or unfortunately, patient didn't come after 2 weeks because he had a colloid fracture and surgery was deferred for another 4 weeks for that. And came for post-op checkup after 4 weeks, no leak, bowel bladder normal, patient is happy, I am also happy for that. So this is the mistake which I have done. Spontaneous healing is possible. So in all cases of EVF, if there in post-operative cases, you put a catheter. In a small rent, it will automatically heal for that. In a bigger rent, I think surgery is necessary. So you have time for that. And God's blessings and patient's destiny is important. Mrs. Y, 30 years, conceived following investigation for primary infertility 7 years, following hysteroscopic annulation and ovulation induction. Patient conceived, twin pregnancy, irregular ANC, uneventful antepartum and postpartum period with 2 healthy female babies born, discharged from the hospital. After 1.5 years, I received a notice from the district consumer court for 5 lakhs compensation for maintenance of second child. Because he wanted a singleton pregnancy, later it was found that it is a blackmailing of the advocate to the doctor. I was rigid to fight the case with my prayer that the proceedings of the court to be recorded, and when the doctor himself is arguing in presence of his counsel. These are the 2 petitions which is given. And unfortunately, the case was dismissed by the district consumer court because of the silly and malafide ground. And I was relieved after mental stress of around 3 months. This is the first consumer case on me I found. I don't know whether there is a second in my life. 2 months after, I again received a notice from the State Consumer Forum regarding the appeal by the party in the higher court for that, because it was rejected. Exactly after 1 week of receipt of the letter, I was being informed by one of his friends that the said petitioner met with a road traffic accident and died on the spot on the road. And when he heard the news about the elder brother was suffering from cardiac disease, when he heard that the younger brother died on the road accident, he came and seeing the younger brother, he also fell and died on the spot. Both the brothers died on the spot in the road. And the 2 wives were crying repeatedly, telling that because of the curse of doctor, God has taken revenge on my husband. I think it was a very painful situation for me. Medical legal cases at times happens to be a case of blackmail. And believe me, if you do not have any malafide intention in the treatment for whatever reasons, God is going to help you for that. And this, remember, this is the truth. And God has been too harsh in this case. And I also felt very bad that God has taken a revenge, a very strong revenge on the 2 brothers for that. And I also cried on that. But the benefit I got it, that this news spread all over the High Court of Orissa. And till date also, my advocates all the advocates are very much afraid of fighting with me in court. Mrs. Y, 36 years, elderly, primary. Conceived following IUI, known hypertensive, on antihypertensive treatment with regular ANC, planned for elective CS for severe hypertension. Now, I did a surgery, uneventful intraoperative period, developed breathlessness, tachycardia, tachypnea 12 hours following surgery. I was skeptical. I was thinking to rule out two conditions. One is the LMWH, I think the embolism, pulmonary embolism. Second is some cardiac conditions for that. And I asked the cardiologist. Cardiologist came, did the echocardiography and revealed dilated cardiomyopathy. Started on dobutamine infusion, settled after 8 hours for that. Suddenly, I was thinking that I'll really miss this case for that. I will lose her, but discharged after 3 days with advice for periodic cardiac follow-up for that. And I learned a lesson from that. And that time onwards, till today, I think peripartum cardiomyopathy is not uncommon in obstetric practice. All of you must have seen it. So, in all cases of chronic hypertension or a hypertension for a long period during pregnancy, elderly female with GDM preferably needs, I will do routinely an echocardiography to diagnose that it is not a case of peripartum cardiomyopathy, because the cardiomyopathy is manifested after delivery for that because of the load. I think this particular case has given me a lesson that these are the cases I always routinely do antepartum, or if I do a cesarean, the preoperative echocardiographic evaluation. And if there's a DCM, I treat it before, or with an adjunct to the surgery, I treat the vasopressors for that. So treatment to prevent acute heart failure. Otherwise, acute heart failure like this will be there. Luckily, the patient could be survived. But it's a preventive obstetric practice to find that, remember that all hypertension, better to do rule out a peripartum cardiomyopathy. By just simple the echocardiography, you can diagnose and find out the ejection fraction. That's enough for that. So therefore, my viewers, lessons learned. Mistakes by human being is a norm, but admitting the mistake is really a boon. Always admit your mistake, introspect yourself, and under-promise and over-deliver. Don't over-promise and under-deliver for that. So again, learn from others' mistake and gain from your mistake, and therefore introspection, critical analysis, and update all the time so that you can do a lot of mistakes till your last phase. Till my last breath, I can make a mistake for that also. But the number will be gradually decreasing. I will not do a same mistake. I can do other mistakes, another mistakes for that. So, practice makes a man perfect. Yes or no? It's no. It is a perfect practice makes a man perfect. Always you do a perfect practice. Otherwise, you do a wrong practice and your mistakes always for that. And the last words, in spite of everything, continue to be one of the best profession in all centuries, past, present, and future. Amidst pains, pleasure is there. We're more ethical, moral, and human. Amalgamation of head, heart, and hand is there. Amalgamation of art, science, and commerce are there. And therefore, we are the winners for that. But ultimately, everything boils down to a standard care. Where from the standard care will come? It is from right decision. Where from the right decision will come? From experience. And where from the experience will come? From wrong decisions for them. And therefore, think about wrong decision. Admit your own mistake. Introspect properly. And therefore, you can improve successfully. You can do more important professionally successful than ever before. So my last advice to all of you, read less, think more. Read for half an hour, think for 1 hour. Talk less, work more. Have will, update the skill. Target scientific development, acquire human development. Be a human being rather than an excellent obstetrician. Pleasure in body, peace in mind, and bliss in soul for that. Thank you very much, ladies and gentlemen, for giving me this opportunity. Believe me, I have done more than 100 mistakes or blunders in my life. A countless number of mistakes in my life. This is you people, Zorbia people has given an opportunity to share few of my mistakes, 22 mistakes. Don't think that this is all my mistakes. I've done more than 100 mistakes in my life. And if time permits, I will share more and more to all of you so that I will also learn many things. You will also learn many things in future for that. Thank you again, Zorvia team.
Thank you very much, sir. Thank you for your honest presentation on mistakes and lessons learned. You shared your real life experiences, challenges, and the valuable lessons gained throughout your career. And that made this session very inspiring and memorable. So, thank you for your sharing your wisdom with us. Sir, with your permission, we can take a few questions.
All right.
permit. So, Dr. Gunjan Bhatnagar, she is asking, do you consider cord around the neck for mode of delivery? And the second question by her is, sir, do I take the cord around the neck? Anything there is a concern?
Well, this is a concern more for the patient than for the obstetrician. Cord around the neck, single loop, double loop, triple loop. I think these are the cases nowadays. By the innovations of the imaging science with ultrasound, it is better known for that and diagnosed more often for that. There is, if you see the evidence and literature, simple for the cord around the neck, you just do it a cesarean. There is no indication. It's not evidence based for that. Simple for the cord. But along with that, if there is a cord around the neck, you find out the length of the cord by ultrasound. If there is a short cord, I think is a concern for you. And you ask the patient that yes, cord around the neck, double cord around the neck with maybe in some cases you may face some cord accidents which cannot be prevented also. But simply by virtue of cord around the neck, you do a cesarean section. I don't think this is indicated for that. You say that majority of the cases with cord around the neck, vaginal delivery is possible for that. It's not a concern for that. But along with that, you find out if the daily fetal movement count is less, if the LICR is less, I think this is an additional factor for intervention.
Thank you. Thank you very much, sir. Thank you. That's all.
That's all?
Yes, sir. That's all, sir.
Thank you.
Thank you, sir.
Thank you.
Please stop the recording.